again for.
Okay, so this may very well be a quick meeting, which is okay. Quick meetings are better than long meetings, long unproductive meetings. But I do know that John has some wound care data for us to look at, so that's a good step in the right direction. I'm just going to look closely at our agenda. So we'll go through everything else and see if Dr. Carlbom comes in. And if he does, we may switch quickly to go to what he has to say in case he has to jump off quickly. He said he was, I think he's training somebody while on calls or something. Chief McKern, you might know more about where he is than I do right now.
Well, if it's knowing where he's been lately, he works in the ICU at Harborview, and he may be in the ICU. So if the patient load gets a little busy, then he gets busy.
So because we know that Commissioner Brotherton has to leave earlier than the rest of us, is there anything either that Commissioner Brotherton has in terms of updates or that you folks want to ask of him, just so we get that in here early on in the meeting?
I'll say I don't have anything in particular to update people on. Still doing our strategic planning with Jefferson Transit. That's what I have to leave for early. We have a conflict here. Mm-hmm. And still, I don't know. I know that Jefferson Transit's biggest problem right now is staffing. So expanding service is a real challenge when you can't even hire anyone when it comes with free CDL training at $23 an hour to start. I mean, it's a great opportunity for anyone with a clean record, but as we know throughout our different agencies, it's a real challenge right now. So they're losing people to early retirement, not able to gain people. So that's the only hiccup I would see in expanding service. You know, they're talking about the Kingston route, and it's not really an either or situation, but both of those take driving capacity. So it is, I think it might come down to a choice of which do we want to, if we only have a little bit of expandable capacity, where do we go?
Mm-hmm. Any questions for Greg?
I do. I was going to ask earlier, Greg, because we've been on the same meetings pretty much consistently, but I forgot to ask the last one and you got busy. So since we're talking South End, I had heard some rumors, you know, the street rumors, you know how they go, and Greg seems to be in the middle of those street rumors. What's the rumor on the trying to convert the end of Washington there, kind of put some homeless folks in some small homes, tiny homes in there? Can you enlighten us about that?
I can. I know that the owner, Mike Saya, is going to sell the place, is taking those little houses off of it. I think it's zoned village commercial, so which is really flexible for housing. And I think Habitat for Humanity is looking at that and another potential site for affordable housing, not homeless housing, but affordable housing for, I'm not sure if it's workforce or senior housing, but there's a lot of challenges with septic capacity there. That's the reason the coffee shop has never really had a much, you know, they finally got the holding tank, but it's kind of old river bottom there, so it doesn't really perk very well. So it would be an expensive Glendon pod probably kind of thing. And Habitat's looking at that in at least one other location, I know, and considering it seriously as an opportunity right now, but no plans are for sure.
Perfect. Thank you. You know, coffee and quill seed, somebody will bring it up. So I thought I'd just pass it on and get some answers there as well.
Yeah.
Thank you, sir. Appreciate that.
Oh, great. So we do have Dr. Carlbom here. Thank you, Greg. I think we should slide right over to him and sort of getting an overview of what happened at the JCEP meeting.
Yeah, thanks, team. Sorry I'm late. I think the meeting went really well. I was, how do I say this? I think we didn't, probably my error was not to have a specific enough ask. But I think, you know, lobbied that naloxone belonged in schools and that we felt pretty strongly as a harm reduction measure, it should be in schools with at least the faculty or the nurses, not necessarily the kids yet. And I felt like people heard that. I think there's a couple good questions about stigma and sort of a little bit more about about revisioning the chip and sort of that vision. I didn't feel like there was as much protestation as I thought I might hear. So I don't know. I thought it went well.
Have you
I was
guys,
sort of on stage, so Lori was maybe a better observer than me.
I was wondering if Chief McCurran, I think you're the, or Greg Brotherton, has anybody heard any fallout or follow up from that meeting?
I'm hiding from social media right now, so I might not be the best person to ask.
Chief McCurran, you haven't heard anything from, I know Trish and Frank were there. Have you had a chance to debrief with either of them?
I have not reached out to Frank. I saw him briefly yesterday at a school event. I'll see him again on Friday. We've got a bunch of school functional events this week. I did have a brief conversation with Dr. Carlbom via some phone conversations, but have not heard anything as far as a reach out. Now, I did hear, Dr. Carlbom, you can and maybe answer up. Frank had mentioned there was some kind of mental health person on staff for next year. Can you confirm that, or did he mention anything about that?
No.
School-based health clinic or in the school-based health clinic program?
In the Colston School District, there was somebody who's going to be on campus. That was something kind of new that I heard kind of just, again, that rumor mill. I thought that's what I had heard, that they were looking at that. So potentially whether or not that's true to fact or whatever the case may be.
37 or 53.
I'm looking at Apple, but I'm not.
Available for a
Not sure where this conversation is because I've missed the last two of these meetings. I'm sorry, and I'm just desperately reading your awesome notes from the last meetings. Thank you, Lori.
But somebody's reading them.
Well, I'm sorry, it's last minute. Everything's like that. Chief McCurran, I think I can speak with confidence on this. MCS Counseling has their counselor. Her name is Anne. I apologize, I don't know her last name. She's new to that situation. She's been deployed there, I don't know, maybe for the last 6 months, but obviously school's been a little in and out with blended learning models, et cetera. So she is part of what we now call sort of the family, the school-based health center family. And we call it a center, not a clinic, because it involves mental health counseling as well as all of our clinical services that we provide through the health department. Anne seems to be doing really well there. She seems to be seeing students, and I think she's there for the long haul. We'd like to keep her. She's attending our advisory committee meetings for the school-based health center and our clinical meetings as well. I also know there's a new counselor through Jumping Mouse down at Brennan. I happen to have met her otherwise, but she seems very proactive and engaged already at an early phase in her employment with them. So that's about the extent that I know about the counseling that's any newer in Quilcene School. I may be missing some parts though, because they've had some outstanding counselors there all along who I know less well.
Perfect. I know they have a nurse, and she came in and I met her for the first time, I want to say in October, November, and she had some serious questions, but they were related to the medical side of things. It was regarding epi, doc, and how she could get more epi, and it was a case of her trying to do some things without calling 911, and I reassured her that wasn't the case. She had to go through the 911 system to make the phone calls.
And Chief McCurran, was that the school nurse? Her name is
yeah. Not the healthcare provider. So
that's right. She's there very, very minimally.
Yes, correct. I did hear
about
that.
2 hours there a week, I believe.
Yeah.
There is a practitioner now, 2 full shift days a week in the school-based health clinic.
Oh, perfect.
Dr. Melinda Bauer, she is an employee of ours, and she is staffing that clinic on Wednesdays and Thursdays.
Well, we're getting to it. That's good. That's good news.
That is good news. There's 2 things I want to follow through on. One is to come back, put a pin in this. I want to come back to the school-based and some things that Denise Banker has just gotten some money for. But I wanted to come back to Dr. Carlbom and as a group think about what is that specific ask that maybe we want to follow up with that group, or with specifically, we know that 2 of the school districts have naloxone policies. And I know that there is the opportunity possibly for evolving that in the Quilcene district. And is that part of what we want to ask, or I'm open to ideas?
I might recommend, I wonder about circling back with Frank. I know he's really busy this week because it's graduation, et cetera. But circling back with him and seeing if he's heard from his school board and how we can support him more in implementing that policy, whether he needs us to be a liaison between the other districts that have a policy to get their policy to give to him, or if, you know, we can help him with that. It seems like the school board was maybe what he was most concerned about. And I didn't get a sense that there was much outward opposition, but maybe it's, you know, more private. I don't know.
John?
Apple, I'm kind of recalling in the fog of my memory that the school-based health centers have naloxone. So we actually do have naloxone in the school, but it can only be used when the provider's in the clinic. Is that accurate?
That's correct. So Dr. Bauer has her emergency kit and she has naloxone on hand. We keep that stocked and refreshed. She's the only one who can use it, but she's also a beacon of education and encouragement around spreading it throughout the school in terms of stigma reduction, training other teachers telling parents, you know, she can be that beacon and she's got time. She's building her caseload there. It's a brand new clinic. So whatever we want to deploy her to do around education or support within the school and how that reaches out into the Quilcene community, I'm happy to deploy that anytime.
I mean, that feels to me like a good next step to offer to Frank to say, hey, the provider in the school-based health center is willing to do some additional training for naloxone, and so that it could be available on more days than just the day that she's there.
So one thing I might point out, Susan O'Brien, our other nurse practitioner at our other schools, she has been that beacon for Timicum. She's helped spread the message, helps Denise within the coalition promote that idea, and then has offered to do trainings. Melinda is a lesser known quantity to the Quilcene community. She's brand new there. And so she is a wonderfully masterful, personable person. And I think she could do this just as well as Susan and in her own way. What I don't know is what the receipt of her is really like. I mean, we've gotten good response. She's engaged with the administration and with Frank and Sean constantly, and she's doing wonderful things there. I think she's being received very well. I have no clue what the parents think of her position there. The school-based health center is new to them. They don't totally know how to use it. They're not always sure about their kids using it confidentially, but I'm not at all proposing that that's a deterrent. I just want to keep that in mind because she is so new there.
I do think that's why it's important that we let Frank and Sean kind of set the pace for that activity, because I know Frank had some reservations when one of the meetings I think that you were not able to attend Apple, he basically said he was concerned about rolling it out. And I think now that Dr. Carlbom's spoken, you know, to at least one school board member, and the idea is a little more familiar if we say, you know, this is available and we're interested in, you know, on your timeline, you know, doing a further rollout. I think that could work well for everybody.
So case in point, when we mobilized really initially the baby steps towards the school-based health center, which was several summers ago, we did follow Frank and Sean's lead. We did do the community sort of addressing and communication and canvassing and surveying of students and parents. I'm not saying you have to do that in this case, but that slow cadence actually lended very well to, if there had been any reservations on the board, then when it was finally brought up for full proposal, it was a unanimous yes, which I have to say I was surprised about. But anyway, I'm glad that begets a new clinic. So
I wonder about suggesting to Frank that they use both providers, both Susan and the newer doc together to do some teacher training. And I wonder if he holds like teacher continuing education over the summer or early at the beginning of the school year. I wonder if it could fit into that schedule.
that's a great idea. Thank you. Lori, do you think you could sort of ping Susan and I about?
I will absolutely do that.
Appreciate that.
And then something else that I wanted to give that sort of is something that came out of Dr. Carlbom's presentation at JCEP was this email back from Christina. And it's a little bit of a sidestep, but it also fits in with the thing that I wanted to tell you about Denise Banker having secured an Empowered Teens Coalition grant for Quilcene, which is for 2 years. I think it's $740,000. Very specific what you can spend it on, but very exciting that she's done it. And I want you all to act surprised and joyful when she tells you. But it connects to this thing that I'm going to read. One of the questions that it just happened before the meeting that Dr. Carlbom presented at, I was outside and waiting with Dr. Engel as we were there about 20 minutes before the meeting started. And one of the things I asked him is in general, how we could be working with the schools to make sure that the things that the Empowered Teen Coalition have and can advocate for has a real advocate for from the school district side, because you can have all the great programs that you want, and you can also have school district folks who are just overwhelmed bandwidth wise. And if there is nobody in the school to really take forward that work that the Empowered Teens Coalition, has plenty of money to execute, then it's kind of, it falls flat-footed. So interestingly, he came back to me and he said, well, I think, the best way you can communicate with the school is through the Empowered Teen Coalition, which, as you know, I've just said, doesn't have a good anchor spot many times in some of the school districts. That was repeated again. Christina Mayer, who is, I think, on the Chimacum School Board, and she was present for Dr. Carlbom's presentation. Dr. Carlbom and I sent out sort of a follow-up email with a copy of the slides and the invitation to ask questions. And she wrote back and said, I feel we have done the policy work, so she's speaking for Chimacum, but there's still work to do in terms of the broader conversations about addiction disorders. And this will take a long while, yet there's some natural starting points with the Empowered Teen Coalition, our school nurse, and the mental health providers that come on campus. So there is a concept in the board's mind, I think, that perhaps there's more success and more bandwidth in anchoring programs in the school through those avenues than we have actually experienced. And I don't know how to fix it, but I'm just sort of raising it to the awareness of the group at this table that we might brainstorm. It does connect, I think, ultimately with Naloxone and just generally us making sure that our kids are well connected to services. Any thoughts on that? Okay, India, go ahead.
I was going to say it's aspirational. I guess it feels like it's going to take a lot of time. And I guess I'm still a little fuzzy on who has that time. If that's, the provider who's in clinic on Wednesday, Thursday, if we're talking about Quilcene, maybe, maybe not. If that's an advocate teacher, if that's Frank, although he seems pretty busy, I can only imagine managing teachers is like herding cats. Mm-hmm. If it's this, empowered teens and who's sort of their coach, I guess I just don't see, I see lots of piecemeal stuff. I don't really see like, I am the one person that's going to be responsible for all of this. And I don't know if there's a way to designate who that one person is, but it worries me that, it's like shouting out in a crowd for someone to do something rather than asking one person to do something that nothing will get done.
I don't know what the answer to this is, but Denise and I have talked at length that you have a grant, that has all kinds of money to get stuff done, but somehow the budget has not allowed for, and could it be reorganized to allow for an actual person that's in the school district as opposed to somebody like Denise who's outside of the school district? But is there some pot of money we could give? And are we back at that issue that Greg's talking about, which is, do we even have a body or, a knowing expert body who could take that role? But the issue is not money. The issue really is the body and the correct connection in the hierarchy of the school district.
And I wonder if our group, maybe then the one thing that we could offer would be helping once they choose who that person is, for whatever small amount of FTE they have for this, helping find appropriate educational resources for them. Is there a one-day class on this? Is there resources that Apple has access to? Does Washington State Department of Health have some training, or, you know, could we find a school district in the state that's not too far away that's done this really successfully and send them there to learn from that equivalent person at this larger or different school district?
And just to clarify in my own mind, when you're talking about what it is that we're trying to learn, is that we're trying to learn how to set up the infrastructure of it, or we're trying to learn the specific piece that Christina Meyer is talking about, which is getting into that broader conversation about addiction disorders?
I think that broader conversation, I
Okay.
think,
Okay.
like, I agree with her. I think naloxone's a Band-Aid, just like, you know, calling the fire department when your garage is on fire is a Band-Aid, whereas maybe you shouldn't have, like, you know, built your bonfire inside your garage.
I'm going to use that somewhere. Okay. Thank you, Commissioner Brotherton. Good to have you here. See you next time. Are we feeling good about this topic? Shall I move forward to the wound care data? John, I'm going to pull that up and I'm going to let you speak to it.
Before we leave the other topic, sorry, is there any, are there any to-dos that I could execute just based on the conversation we're trying to wrap up? I see that there's a theoretical question, and then it sounds like there's two maybe levels. There's maybe a specific person with advocacy around the sort of general substance use issues and the need for naloxone, though it's a Band-Aid. And then there seems like there's a tactical question over deploying naloxone in the schools and how that'll roll out. I don't want to get stuck in that. You guys have had more conversation.
I'll tell you what I would suggest, but I don't know. This is just Lori trying to gather, you know, people that I think might know about it. I think if we had a conversation that was at least Susan O'Brien, who seems to know a lot just because she's been there for so much, about how to navigate and strategize that infrastructure problem. If we got Denise, myself, Susan, and maybe you, just to sort of have a rounded perspective and brainstormed it a little bit on both of those questions. That might be a place to start, and at least we might generate some more options for ourselves in terms of next steps.
And that would touch two schools at once, two school districts at once. That'd be Chimicum and Quilcene, although I know Chimicum's already kind of on board. But yeah, I'm happy to do that. Sorry to take us back.
Okay, and I'm not averse to having any of the other school-based health folks, be it mental health or otherwise. I just happen to know those that I have named. Susan, I know. Denise, I know, is the one with the challenge and the money. And we'd really like to be good about using that money effectively in Quilcene, where we've just gotten it.
The School-Based Health Center Advisory Committee meeting, which happens, I think, every other month, might ultimately be the place where there could be some delegation of some of these tasks. But let's talk internally a little more with Denise and Susan about sort of a process.
And I think there's another tactical thing that we need to do, which is contact Frank and Sean and let them know that we're available to you know, do a further rollout if and when they're interested.
So I will create some notes from this meeting, and out of that pull the specifics, and I'll probably wait until Frank has gotten through his graduation week for rolling back and touching it. And Trish was also there. I'd be very interested in what Trish took away from that, or her perspective, you know, about what went well or that sort of thing. And if any of you get some feedback, Chief McKern, if you happen to have, we'd love to know genuinely what people took away from that meeting, so that we can sort of make sure our steps are based in some reality.
I think the other piece that we're going to have to lean on with the schools too is how that, I think you summed it up really well, Dr. Carlbom, is how the parents are receiving some of this. One of the issues we're having at this end that I'm hearing already is that there's a lot of sources for folks in town to do outreach, i.e. mental health, AA, NA meetings. We don't have them here in Quilcene. And I'm hearing that from a lot of the folks that they're looking for that outreach. And we seem to have an increase in certain areas of our community in Quilcene that we're seeing that naloxone again. And Dr. Carlbom, you can echo, we've seen more and more of that over the last few months. And I think it's because there's just nothing there for them to go to. Suggestion might be not only do we include the schools, but we probably want to reach out to the faith-based organizations. We're pretty strong in that in the Quilcene area. We've got, I think this is the only community I've ever been in where there's 4 churches within a 2-mile radius of downtown Quilcene. And so maybe by chance we need to reach out to, they've got one leader, and that's Dan Ward, who's the church right behind our office here, and see if Dan and Dana can kind of reach out to that faith-based organizations as well.
So I did reach out to Dana, and this was just as she and Dan were leaving on vacation. We've talked a few times. She's willing to talk to me on the phone, less willing, I think, to hop on a meeting in general. And it might be just that she had a little bit of pandemic exhaustion serving her community. And so I thought I would reach back to her in July just to check in again and see where she's at. And you're absolutely right, Chief McKern. If we could have some faith-based reps, and if you know of someone other than Dan or Dana, I'd welcome insight and the opportunity to start to maybe develop enough relationship to bring them into the conversation.
Perfect. Yep.
Lori Tinker, it is good to have you here, and I'm happy you could join us whenever you got here. I think I'm going to turn to John and look at this data. And please let me bring it up. And John, I'll let you set up why we're looking at it, et cetera, et cetera. Is that visible? Great.
Sorry, just getting off mute. We've been discussing kind of wound care related to potential substance use disorder, and trying to get some information from South County about the incidence of wound care in the community. And what this is, it's data from the our home health agency who does visits to the South County region. And it's totaling up the number of cases, number of times that they visited South County, so there's 2 things on the sheet there. One is the number to the left is the number of patients. So the total number of patients seen was 27. And then you can see, in addition to that, are the total number of wound visits. And you can see like one of the patients had 115 visits for a pressure ulcer. So I think most of the wounds that would be related to substance use disorder would probably be under the surgical wound rather than stasis ulcer or pressure ulcer. So those are the ones that are potentially those cases. And this is data from an entire year, the year 2020. So you can kind of get an idea of the incidence of wounds, and you can see that there is a prevalence of surgical wounds, but that would cover other wounds besides those that are related to substance use disorder. So question, Apple, it looks like you've got one.
My nursing skills are so dull. I'm sorry, leadership has. Would you do me a little nursing 101? Why would surgical wound incidents be correlated with substance use instances, or?
Because most of those would have had some level of debridement done in their treatment, and they probably had some kind of a surgical intervention at some point, and then were put on antibiotics and had follow-up with the wound nurse.
Okay.
And if I could add, I don't know how the emerge docs here are draining the abscesses. Historically, abscesses have been drained by opening the entire size of the abscess and then packing it and letting it heal from the inside out. There's some newer techniques that use putting a piece of rubber or latex through the wound from 2 holes on either side and irrigating it out that cause a little bit less of a wound. But I'm not sure that's a pretty cutting edge technique. So I'm not sure. So I imagine a lot of the surgical wounds are, I have a big wound because they had to drain pus and now that thing needs care.
So I'd say the incidence is somewhat less than 17, I'd be surprised if half of those wounds were related to substance use disorder. Some, you know, on the order of 5 or 6, maybe over a year. That's a total guess. And Lori, if you have any thoughts, be interested in or Dr. Carlbom, interested in your thoughts as well, whether that seems like a reasonable projection.
John, I was just going to ask you a question. So I think what I hear you saying is it's not probably worth a ton of effort to try to expand wound care beyond the clinic. Is that what you're saying? Because the number is so small?
I mean, I wasn't ready to make that recommendation, but the number does seem pretty small. And, you know, we do have, you know, Jefferson Healthcare does have some remote services that are available in the community through home health. So it is possible to have some treatment done in South County without people having to travel, which is also nice that we have that service available. So I'm thinking, in my opinion, we don't need to do a lot of expansion for wound care for substance use disorder. And Apple, looked like you had a question.
Maybe this isn't the forum to say this, I don't know, but is Elizabeth Ollinger moved on from her position and somebody else coming in? It's a rumor only in my ears. I don't.
I will tell you what I know, and I'm not couching anything. This is everything that I know, which is she's on a medical leave right now, and we don't know her anticipated return.
So she has an interim person, but it could be long.
Candace Byers is down there 1 day a week right now.
Okay, I need to know that for multiple reasons, including this, but
yeah. And you know, I know that we have a long-term commitment to staffing that clinic on a better basis than 1 day a week. So once the situation with Elizabeth declares itself, I'm sure we'll either have Elizabeth back or be recruiting for that position.
And of the 17, sort of the N equals 17 for the surgical wound care circumstances, the spreadsheet left before I could look, but is there a way to know that the South County Clinic does some portion of those at any regular interval? And I guess the further question is, do we have any clue if any of those are related to substance use issues?
Yeah, we don't, unfortunately. And, you know, since that covers, I know my mom lived in Quilcene and chopped her foot with an axe. And the home health nurses came out and saw her at home. So, and that was actually a surgical wound because it was debrid and you know, drains were put in by a surgeon. So, you know, I'm sure there are wounds like that. And I think, you know, post-surgical site infections would probably also be in that category. So I'd say, you know, a very conservative number would be 6 that might be related to substance use, and it's probably lower than that would be my guess. But
this may be sort of pushing the envelope a little, just clipping here in my mind.
That's what we do, Apple.
Sorry. It's like there's just
I'm dead serious, man. That's what we do. We push the envelope.
The proverbial we. Is there any, and this is a fantasy, this isn't actually anything that's written in stone, but if there were more, once there is more emphasis on maybe staffing this future, you know, syringe exchange program or what have you, I don't know what you're going to call it, but would it not behoove, I mean, in our case here at Public Health, we only have nurses staffing SEP. And that's a commitment that we've made. I don't know that it's the case everywhere in the state, but in our case it is. And just this morning, wound care, come to UW and take a course all through the year. And I've never gotten this one before, but I just glancing at it in this conversation, and I'm thinking my own nurses who do some wound care, but mostly triage it next door. They always could use continuing education, especially with regard to substance use related wounds. So I'm just thinking, you know, long-term staffing that ever becomes sort of actualized in this effort in South County may be the source of some at least nursing level wound care. But it all depends on how we staff those situations in South County. I don't know if the future SEP program that there, when and if it happens, would have nursing staff or not. Of course, that's my pitch.
Yeah, and you know, I'm reaching into the foggy memory of my nursing background, which is probably goes further back than you. But the one thing I do know about wound care is that it's a pretty rapidly evolving science, that a lot of what I did, you know, 10 years ago when I was last nursing is not being used now for wound care. So I think, you know, having somebody that knows the latest techniques is pretty important.
Yep.
So, and I think, you know, Apple, to get at the core of your question, I think we need, as we put that program together, whatever that looks like, we need to make sure we apply the right resources to that. And I'm hoping that the Quilcene Clinic will be involved in that, because I mean, it makes sense to me that they would go to a place where they, you know, if they did have a wound infection related to their substance use disorder, that they could be seen right away for that and be treated for it. And, you know, rather than having to go from point A to point B to point C and get shuffled around. So
I agree. That's sort of why I selfishly asked about Elizabeth, because I just was curious that staffing that's going on down there and they're available.
Stay tuned.
Do you have a sense, Apple, if the syringe exchange that's happening up here in Port Townsend, if that happens on occasion, people come in, they're exchanging needles, you note that or they bring up that there's wound care to be dealt with? Do
Yes.
you know? It is. Okay.
Absolutely.
Great.
And some of it is very minimally managed here on site at the SEP clinic, which is not necessarily an exam room. And it's an education room where needles can be dirty for clean, can be exchanged. And then other education is provided. It's not an exam room with a lot of, you know,
outfitted for.
It's not a clinical room per se. And then that's triaged, obviously, beyond our capacity over to the hospital. But yes, it happens regularly. And Margie and Julia and Lisa, you know, they're very on top of that. And they're also very on top of the educational component, because they can sit with an SEP client for some time. It's, you know, it's not a build clinic visit. It's a grant funded position where they can take time with their clients and really talk through education on their own body, as well as how to help their friends in secondary exchange deal with their own wounds or come in and see us because we're trusted by that source person.
John, I know that we had talked a little bit about using the home health care tick box to ensure follow-up, and I don't know if that's more conversation belongs here or there's any more to add to that conversation. I just wanted to bring it up in case there was. Does this ring a bell? Do I need to bring up the notes that talk about
Yeah, it's not ringing a bell. Sorry,
I can add to that. So at a monthly meeting that I have with Lori Tinker, the ED nurse manager and the ED physician leader, we did bring it up and asked that the ED physicians be reminded to check home health so that we could make sure we're capturing all these cases, even if it's, you know, just 1 or 2 home health visits, that way we could at least sort of get a better sense of the numbers. So maybe, you know, in 6 months or a year, maybe that spreadsheet will have more surgical wounds.
Okay, great.
So it might just be worthwhile as maybe in 6 months to repeat the query of the health record and see if the number is still as small as it is here.
Thank you for doing that. And then I want to circle back to Chief McCurran. Go ahead. I'll ask my question, but you tell us yours first.
Probably going to be the question you're asking. So John, are these post-discharge surgery patients? That was the question I brought up earlier. And I guess my previous life in Mason County, that was our first outreach for community paramedicine, was wound care, but it was a standpoint of 3 to 4 days post-surgery, making sure that they were taking their meds, they were doing some outreach. So that was my question: is that where we're getting this data from? Yeah,
it's from our home, you know, from our home health agency, but it is, as you can see, most of those are post-surgical patients, and so it is the surgeon filled it, you know, tick the box to do a home health referral on his post-surgical patient with an infection or with a debridement of a wound.
Perfect. Thank you. I thought that's the answer.
Okay, and I was circling back to Chief McKern to make sure we had answered whatever question it was that you'd given us that started the whole ball a couple of meetings ago. Okay, so let me just look quickly at our agenda. I think that I have covered everything that we have the people here to cover. Again, Sheriff Nole let me know this morning that he wasn't going to be able to make it. I'll keep chasing him down for data that we were hoping to get around sort of where the navigator calls are showing up and they're serving them. And to give you guys a chance to meet Jonathan Walsh, if you've not already.
And Lori, I can give just a quick update, which we've kind of talked about, but in terms of the Quilcene Clinic being the primary distribution for the naloxone in South County, you know, Heidi Matthews, who is the director of that clinic, feels like until the situation with Dr. Ollinger or Elizabeth Ollinger is stabilized, it's really difficult to make that commitment. So once that situation is resolved, then I think we'll have an answer on that question.
Okay. Dr. Carlbom.
I can certainly give an update. I had a very productive meeting with the Tacoma Fire Department about leave behind naloxone. Would now be a good time to give a quick update.
Yeah.
So meeting with them, with Washington State Department of Health, Sean, I forget his last name, but he's in charge of substance abuse and naloxone distribution through the state, as well as representative from the University of Washington Addiction Services. I forget their acronym is ADAI.
ADAI, and I think it's Sean Hammerly, maybe.
Yes, thank you. Good meeting with the city of Tacoma. They, I think, have a few more resources than I think Jefferson County will. They have the luxury of having 2 nurses that work for them exclusively, caring for patients and doing Suboxone microinduction at the scene of where the patient gets resuscitated from with naloxone. So patient gets resuscitated, is in acute withdrawal from naloxone. And then a nurse will come and spend almost 2 hours with them because they're sort of primed. They've moved from pre-contemplative to contemplative about switching to using chronic medications for their chronic disorder rather than heroin or other opioids, and spends almost 2 hours with them, starting them on Suboxone. This was because in their experience, when they call the next day, they either never reach the person because they don't really have a working cell phone, or the person has used again and is no longer interested. I don't think Jefferson County has those resources. Nonetheless, I still think there may be value in having our EMS providers have the ability to give naloxone to people who have been resuscitated with naloxone or who have used their own and need a resupply. And I think that will hopefully, I need to do some meetings with all the fire chiefs through the summer, hopefully with the navigators also through the summer, hopefully with Apple and her crew through the summer, with maybe a go live of October. And so that we can do some education in September for all our providers, including having Sean and someone from ADAI come in, as well as the battalion chief from Tacoma, come and talk a little bit about how do you talk to someone after they've overdosed, and just how to not be awkward about it, but just to be, you know, truthful and with that harm reduction point of view. And then sort of how to do those kits. I will probably ask maybe that the cache be at East Jefferson Fire and Rescue and that other districts come or ask their MSO to deliver it to them when they need resupply. Because I think that there's sort of an extra person now. Tammy Ridgway is the medical services officer in charge of EMS. And I think that could be a natural fit for her if Chief Black is willing. So stay tuned. I think it's promising. I think some good education stuff. ADAI has some stuff you can order in both English and Spanish. The state has stuff you can print on your own. The state has a video. So in the kit, when you hand it out, you could include some information. The ADAI one is sort of, so I've overdosed, now what? They've included that, some stuff on opioids, and they have a new little like handout about methamphetamine withdrawal and methamphetamine use, which I think would be a good fit. And then the state has a link to a video, a YouTube video that is in English with Spanish subtitles. So I think hopefully maybe it can be a project through the summer and fall if the fire chiefs are willing. Hopefully I can convince them. again, I think this is a Band-Aid, and I still think we need to be focusing our energy on community support, on access to other options like the AA and NA stuff that the chief mentioned. And I would envision that the sort of support card that you guys have with all the resources in Jefferson County should go in the kit also. So people, not only is it like, oh, here's this antidote, this rescue, but also, please, here's some other options so that you can start to break the cycle.
Great. That's really good news. And I mean, I can see work ahead of us, but the outcome of it really, really good for Jefferson County.
And I
John?
think the drugs will be free through the state. Their grant cycle restarts in October, and they're envisioning it will get refunded unless there's some catastrophe. And so that timing works really well.
And David, refresh my memory. Where do the drugs come to, and where are they distributed from?
Yeah, I think I would envision that they would come to Tammy, wherever she receives her drugs. Otherwise, they're shipped by a drug company
It's
called
the
McKesson.
corner of Lawrence and no, never mind.
Yeah, I'm not sure. And it would be cash there, and then we would dole them out to each fire district so that every responding vehicle had 1 or 2 kits, and had a par of a few at their station, but that we wouldn't envision people going necessarily to each individual fire station to get kits. We wouldn't announce that, but just that if they're on a run and someone was in need of it, they could give it to any adult or emancipated minor, frankly, in my opinion, who we've thought had need for it. So the only requirement of the state is that we keep a log of how many we passed out, not who we passed them out to, but how many, and whether or not it was a resupply or a first time leave behind. And I think that's something that I hopefully can charge Tammy with doing.
And that's something that's that won't say a word. And that's something that's done under your authority and your licensure. It's not going to have to come through our pharmacy or it's okay. Cool
Not at all.
beans.
Yeah, I think I would love to partner with the ED to have a similar program at hopefully a similar time, so that there was sort of just more uniform
Some continuity. Yeah, absolutely.
I think Lori, you might know more about this than I do, but I think there's some work being done right now for the hospital to provide naloxone to those who come in and overdose. So I think that might.
It is on agendas of discussion and talking. So yeah.
Yeah, and the state program, I can link you up with Sean, seems pretty robust, and naloxone right now is a little cheaper, but I think we'll get a little bit more expensive again probably through the summer. And so I think from a cost point of view, it's nice to have the cost of the medication taken care of. Oh, and the only other bleeding edge news about nasal naloxone is there is a 8 milligram nasal spray being manufactured that will be out in about a month, which is way too much. Yeah, worries me. I worry it's too much. I personally feel 2 milligrams intranasal is the right dose, maybe 4, 8.
My father used to call us snoutful.
Yes. So we'll see.
So what's the thrust for such high dosage?
I think it's worry across the country about synthetics. So I think, if we were to have carfentanil or remifentanil or, just fentanyl, then I think that's the right dose. But we have maybe a case in Quilcene. The patient woke up with not very much, so I'm a little skeptical. But certainly maybe 1 or 2 cases in Bellingham. So maybe carfentanil is coming. The team at ADAI was sort of like, no, we're actually not as convinced yet, but I'm not sure. So they're working on updating their current data, which should be out in a month. So hopefully some more data about synthetic versus non-synthetic opioids from them.
I know I sent that email, Dr. Carlbom, that we'd gotten from someone in Mason County who was very much in support of that huge dose. So I don't know if they've got a different demographic that they're treating down there, but it is interesting, the wide range of feedback about that.
Yeah, I just worry, I think a lot of people recognize the suppressive effect, and they mix their opioids with sympathomimetics, methamphetamine, or cocaine, and then you end up with this unmitigated sympathomimetic, which then just means you have sort of a fight on your hands after you wake the person up. So
Mhm.
I don't know.
And then you've got to give them that, and then you got to give them this.
Yeah.
Um,
Sometimes just enough is the right dose.
It's the right dose. Anybody else on that topic? Or any other topic before I let you go? I'd love to connect in with Dr. Carlbom separately if we're good with what was on the agenda. I really appreciate you guys coming to this meeting. I know it's I think of it as a couple of things. It is South County harm reduction, but I also know that we can get a commissioner here. So hopefully it's a direct line for the folks who are in that area to be able to talk directly with Commissioner Brotherton, and, you know, at least once a month. I really appreciate the hospital being here. Dr. Carlbom, you're of course a huge light in terms of what we're trying to get done. And Apple, you know so much about what's going on at the community level. I recognize over the next meeting or two, we either might find it really easy to get the school district folks here, or they may really just not want to be here because it's their summer and they've got lots of other things to do. So I just wanted to check in with this group. Are you okay with us still continuing to hold this once a month time, even through the summer, which may mean we don't have all of our school district folks attending? Okay, all right.
It's call dependent. Well, call dependent. You know, obviously our traffic's going to start to increase dramatically, so call dependent. We'll surely make sure. I want to comment, Dr. Carlbom, I think you're on the right track. I'll certainly will involve the MS Council. I know we don't meet again until September, but we certainly can convene a special subgroup to work through that process as well. This will probably be Lori's last meeting. We want to thank her for her time. She's decided to retire. And so, yeah, I know. Dr. Carlbom did not approve it. She's doing it on her own. So we'll have to go from there. But hopefully we'll have a replacement for Lori. But it's going to take 2 or 3 people to replace Lori. That's for sure.
Isn't this a good time for somebody to step in and say, I look far too young to be retiring?
And she does. She does.
Yeah, I'd say I have used that line, I think, once too often. So, but anyway, yeah, well, we will see. So we'll see. But I would certainly will attend if I'm here. So.
Oh, great. Thank you. I have some concerns because hospital-wise, we know that John's going to be retiring. Lori's going to be retiring. I'm hoping that we come up with a good hospital connection, and if between the two of you help us make sure that person is at this meeting. I think it's an important connection to the South County, and it's nice to have everybody sort of easily on a call and Zoom.
Well, since John's mom isn't cool, seeing John has to stay.
All right. Well, I'll let the rest of you go. And Dr. Carlbom, if you have 2 minutes for John and I, that would be great. Okay. Thank you, you guys. Have a great rest of the day.
Lori, I've just got to take a call real quick, but I'll listen in.
Okay, great. So let me just turn off this recording.